treatment algorithms and just kind of what to look for in general that may be out there that, is seeing us, but we don't always see it. So I have no financial disclosures. At the end of this, we'd like to be able to identify common adolescent and young adult hip conditions, be able to properly diagnose and triage these. In the young adult and with hip and sports medicine injuries, be able to better manage them and properly refer them to the appropriate individuals if needed. So this is an important topic. We know that this accounts for about $1.8 billion in healthcare-related costs annually, with about a third of all school children who engage in these organized sports sustaining some sort of injury that's going to require medical attention. We get 30 million annual injuries across the world, and 62% of organized sports-related injuries will occur during practice. The CDC has put out some statements that they feel like half of these could be prevented, so of course, good recognition, training, and measures to avoid these are important. We know that this varies by sport as well as the type of injury. We see that certain sports such as football or wrestling and gymnastics approaching almost a 50% rate of injury within high school sports. We have a lot of challenging factors that we deal with. We have a lot of different athletic abilities, often engaging on the same field. Often these folks will go outside and participate in unsupervised activities. Younger adults have developing anatomy, which presents unique biology compared to adults. They're playing on multiple teams. There's really no off-season for a lot of these athletes. And then one thing that's often overlooked is the psychosocial impact on a developing athlete. And what does this mean? So anyone that has a sports-related injury that may require surgical intervention or some sort of more advanced impact, such as a fracture, they'll miss on average 10 days of school. 36% will fail a test, and on top of that, it'll negatively impact their academic performance. So something to just keep in mind. Of course, we want to keep these folks healthy. So does that mean that if our kids are participating in sports and weight training, it's going to lead to an injury? No, but it does happen. There's a lot of different flavors of these injuries. We have acute injuries, which those are going to be your dislocations, your ligament ruptures, your fractures, and then your chronic injuries. These are your overuse injuries, the no off-season type, and those can often predispose an athlete to an acute injury. So when we look specifically at the hip and groin, we start with the most commons, the thing we see all the time. These are going to be your typical groin pull, your adductor strain. They're going to resolve pretty quickly as long as we take the appropriate measures to rest and avoid the provocative sport or activity that's causing that, and should within 5 to 10 weeks essentially be gone. Your pelvic apophysitis, these are going to be your conditions that are going to be around the growth centers. These are going to be the typical bone growth exceeding the muscle's ability to stretch in your developing young adolescent. Again, should also resolve if we alleviate and remove the event or sport that's causing this. With a little bit more force or injury, we can get avulsion injuries. The sartorius attaching to the ASIS, often involved in rotational injuries such as batting. We want to be cognizant and aware of that. Pain directly over the front of the hip on the bony prominences. We can identify this using both x-ray and physical exam findings. A little bit lower down where the rectus inserts, we'll see AIIS avulsions. One thing that can be a little bit unique here is that these can be associated with a little bit deeper pathology specifically to the hip and the labrum itself. So what we want to do is identify those individuals that are going to have pain that doesn't go away after that conservative treatment period, 6 to 12 weeks. So we know that hip pain in a young adult or a young athlete in the adolescence lasting greater than 3 months has a pretty high incidence of something called femoral acetabular impingement, and that's usually associated with a labral tear. So what is this? Well, it's an abnormal shape to the hip joint. It causes a pinching with hip flexion, and this can result in damage to the cartilage and the labrum, and eventually even lead to early onset arthritis in a young adult. These abnormal bumps can develop in utero. They develop in relation to the sport that this athlete plays. Much like we know the throwing athlete has anatomic changes that can occur in the shoulder, On the throwing side, the same can be said for certain sports in the hip. And this is usually presenting in adolescence. So the definition specifically is an abnormal abutment between the proximal femur and the acetabulum, and it's defined in two different types of patterns, which I'll go over briefly, both a cam and pincer type, as well as you can have a combination of both. The cam type impingement is probably the one we'll more commonly see in the younger patients. This is an x-ray of a hip. You can see there's an abnormal bump kind of protruding there. This is a representation of the actual bony acetabulum, with the red representing the labrum. This cartoon drawing kind of demonstrates the abnormal sphericity that we see here, and then we'll take this through a series of motions where we see an actual impingement and lifting off of that labrum, resulting in injury to that cartilage over various years of sports. So this cartilage damage occurs at the anterior superior portion of the acetabulum, and it is often pushed off. Sometimes the labrum will remain intact, which can make this a little bit of a difficult diagnosis, and it's largely physical exam based as well as MRI, but we may see again, even on MRI, a normal labrum, but there is a delamination that we see when we directly look at that through a scope. So this is your young male patient that comes in with groin pain that's been going on for greater than 3 months. So pincer type FAI is a little bit different. This is where the socket has a misshapen anatomy, if you will, or orientation. What we see here is an abnormal abutment causing damage to the labrum by a leverage type moment that occurs. So this is going to occur a little bit in females more commonly, usually as they approach middle age. It does cause repetitive trauma to that labrum. It's not to say that you cannot have both of these as a mixed type of impingement. So why do we care about this? Does it mean that everyone's going to go on to develop severe hip arthritis and walk like this gentleman? No. However, it affects major league sports in a pretty large way. Multiple athletes often reach a plateau and cause and have to stop their sport of choice secondary to this pain. And it can be very impactful and difficult to treat, and you have these lingering kind of sideline complaints of my hip hurts without any real way to identify what that is. So it's important to realize that this is not a disease in itself. It's just a mechanism by which damage can occur and the hip can fail. Sometimes we'll have an athlete come to us and say, when I was born, this happened, or when I was younger, my mom said this, or my dad said this. But oftentimes that's not the case. And we'll focus more on this idiopathic variety today, where it's not necessarily as common. So again, predominance more often males than females, and those that are physically active. We're seeing this come on slowly, so it's not obvious. They're not getting hit on a field or coming off and saying, okay, this happened and I need to go see a doctor. It's going to be the one that's coming to training room all the time, presenting with, again, groin pain. It's often very, very difficult to pinpoint this, and if they go to their pediatrician, they'll often get worked up a lot of times for things like low back problems, inguinal hernias we find often, which may or may not need to be addressed, but they may not be the actual source of the groin pain. So something to really keep in mind, that when you have that patient, again, just make sure that when it's been going on a long time and they present like that, that it gets looked at by someone who has experience in this field. So what we're going to see is difficulty with squatting. Sit-ups are the main culprit that we hear patients often complaining about being able to do, even putting on their shoes, squatting down for those type of activities. The pain is almost always groin related. They may even present and say there's a mechanical locking or catching that occurs when they're rotating or squatting down, something to consider. And again, this is usually a slow onset. There can be some distribution in this pain that goes down the front of the thigh, that there's an overlap in that. So one other thing to look at. But most commonly what I see, and what is probably one of the most sensitive and specific complaints that they'll present is the C sign. So they're going to come in pointing around to the back buttock with their thumb, and their fingers will wrap towards the groin. And they'll say, it just hurts, and they'll hold their hip. It's also been described as a grab sign that we see. So one of the exam tests that's very sensitive with 100% sensitivity is your fader, or flexion, adduction, and internal rotation. So you're going to have them supine. You're going to bring that hip up, flex it as far as you can go, 90 or beyond, and you start to internally rotate that hip. That will often reproduce the pain, and they'll kind of stop you or catch and push you away as you get close. The other thing you can note is any asymmetry in the amount of range of motion one would have versus the contralateral leg. You can also look at some posterior impingement signs, although I feel this to be less specific and often can be kind of confused with the test that looks for any tightness in your hip flexors, like a Thomas type test. But you can get some posterior impingement by bringing them off the end of the bed and extending them. More often in the females, you'll hear them kind of be apprehensive as you bring that down if they have any hip dysplasia, which we're not really talking about, but it is another condition which can occur, which is the opposite of overcoverage, but when the hip socket's too shallow, and they may feel this sensation of apprehension as you bring them down, and there may even be a pop, or they want it to pop. And then lastly, when we bring these patients up into a forced flexed position, you may see them want to naturally externally rotate out that hip as opposed to being able to even go straight up or internal at all. We have some patients where there is no internal rotation, and they just naturally will fall out into this externally rotated position, which is, again, due to that abnormal abutment of the socket with the ball. We don't want to forget about the lumbar spine, our snapping hip, and then our SI joint. Those all can be overlapping in the way they present. However, again, the groin pain is kind of the hallmark of the FAI. I'll briefly go through some radiographic kind of evaluation just so we can get an idea. This is just your AP pelvis x-ray. We always take multiple views, but these would all be potentially read as normal at any urgent care or just general radiographic location, mainly because they're fairly normal hips. It takes someone who's looking at the exam of a patient knowing that these complaints exist and then going back to these x-rays to evaluate it. We can see that there's a difference in the coverage. Some sockets are very shallow, some are very deep. The ones that are going to be deeper, that's your pincer type impingement. We can also get an idea just from this 2D x-ray on what the orientation of the cup is. This is a 3D picture. Some folks, the acetabulum will point in a kind of a front-facing direction, and sometimes this will be more directed in what we call a retroverted position, where they'll come up and impinge earlier just based upon the fact that the cup is oriented differently. On the bony anatomy, we'll see this pistol grip deformity where there's no real offset anymore on that ball transitioning to the neck. Hence the name, the pistol grip deformity. This is on the lateral side. We see the same exact thing. So oftentimes we get to this point, we have positive exam findings, we have x-rays which demonstrate some changes, so we're going to want an MRI, and this is where we're going to identify those labral tears. So we're still talking about where this comes from and what sport is going to predispose this, but the bottom line is it's got to be everything together. It's got to be a symptomatic patient with positive exam findings. We know that if we x-ray every collegiate level football player, we're going to find positive x-rays, but that in itself doesn't warrant treatment or any further intervention. However, when you have the association of a labral tear, it may. So there's a lot still in its infancy surrounding this topic. I like to talk about it and bring it up just so we can get the awareness out there that it does exist, and it's often hard to diagnose and often something that plagues an athlete and keeps them from performing at the level that they can get to. And it can become very symptomatic as they get older and present a lot of problems in young adulthood and even middle age. So the first line of treatment for this, of course, would always be non-operative. These are the things that we're going to implement, which is just avoiding the activities that, that hurt. Usually that's going to be deep flexion. You may see us write things on, some prescriptions where it says no hip flexion greater than 90 degrees and squats 90 and above. But when there's a labral tear, these modalities often fail, and you'll often have worsening of the symptoms. So it may be that for the first 2 years, this patient had general hip pain that would come and go and get worse based upon the sporting activity, but then all of a sudden, maybe that's now turned into a tear from this repetitive trauma. If that's the case, these modalities, this period of rest just won't work anymore. And it's at that point that you need to also look at further evaluation. So from a historical perspective, open surgical hip procedures are really not done these days. It's pretty much all treated exclusively through arthroscopic means for most of this impingement type stuff. And we can treat both the femoral side and the acetabular side. These are just some intraoperative scope pictures. We see the probe kind of pushing down on the labrum there, where we see that tear of the labrum versus the one on the opposite side where the repair has been completed. And then when the hip is then placed back into the joint, that bump has been resected, so you no longer have that impinging. Again, open surgical hip treatments are largely historic in nature, but we can see the difference in the sphericity and removing that bump, and then the labral repair. So we know that labral repair is associated with better outcomes than just debridement alone. We can talk a little bit about which one is I guess, the main culprit. We really don't know, but we know that there's really rarely labral tears in the absence of bony anatomy. So just plain X-ray, once again, looked at with the eyes of someone knowledgeable on this topic, will be able to identify the majority of folks that are probably going to need more workup. So again, we do see labral tears in asymptomatic individuals, so we put it all together. These are the patients, again, that are going to have the exam findings, the complaints in their history, and the actual radiographic findings and MRI findings. So I think it's important for us not to avoid any type of surgical intervention with these type of injuries, because patients do better when this is identified early. If we treat this within 1 year, they have an average return to play within 3 months. And if we treat this after the year mark, it's usually closer to 4 to 6. And I think that's an important concept to think about. And again, we know that the repetitive trauma of that abutment is going to cause continued damage. So I think it's more impactful to just identify this early. So hopefully that helps and highlights a little bit of a unique topic. And happy to answer any questions. No, we would remove that. So during the surgical procedure, if you're talking about the pincer type or the over coverage, usually what will happen is we'll actually remove the bone on that side as well using the x-ray. When we looked at the x-rays when I talked about the orientation, that retroversion, we'll see that line change on intraoperative x-rays as we do it, and we get rid of that. And then you reattach the labrum back at the new resected level. So those would both be treated together as a mixed type deformity.